Okay, let's jump in. When you're studying for your mental health nursing exam, uh, understanding conditions like schizophrenia can feel pretty overwhelming, right?
Oh, absolutely. It's incredibly
Yeah,
complex.
it's not just one thing, is it? It's this whole spectrum of experiences.
Exactly. And for nurses, getting a solid grip on this stuff isn't just, about passing an exam. It's really fundamental to giving effective, safe, and compassionate care.
Especially when someone's perception of reality is so different.
Precisely.
And that's why we're diving deep today. Think of this as us walking through your study guide on schizophrenia spectrum disorders.
Mm-hmm.
Our goal here is to really pull out the key stuff, the definitions, the symptom differences, the med facts, the assessment points your source highlights, the things you absolutely need to know.
Yeah, we want to help you connect the dots, basically. Link those glossary terms in the text to what you'll actually see on the exam, especially around assessment and patient safety.
Right. So let's build that foundation. Your guide starts with psychosis. What's the core idea there?
Well, at its heart, psychosis is really about a break from reality. Your source defines it as altered cognition, altered perception,
Okay.
and importantly, an impaired ability to test reality.
Impaired reality testing.
Hmm.
So struggling to know what's real.
Exactly. Reality testing is that sort of background process we all use to tell the difference between our internal thoughts and feelings and what's actually happening outside us.
Right. We do it automatically.
We do. And in psychosis, that function is impaired. So the person genuinely believes, their hallucinations or delusions are real external events, not internal experiences.
Okay, that makes sense. So psychosis is that breakdown. Now, your source material talks about phases, like how schizophrenia might unfold. Can you walk us through those, prodromal versus acute?
Yeah, the guide makes a clear distinction. The prodromal phase is the earlier stage. It can last months, sometimes even years.
What?
And here you see more subtle changes. The source mentions things like mild shifts in thinking, maybe some odd ideas, changes in mood. Reality testing might be a bit shaky. Functioning can decline, but it's not usually completely disrupting their life yet.
Subtle changes. Maybe things you'd only connect looking back.
Often, yes. Then you get the acute phase, and this is where the really severe psychotic symptoms burst through.
Like hallucinations, delusions?
Exactly. Prominent hallucinations, delusions, really disorganized thinking. These symptoms cause major problems with functioning, often leading to hospitalization or needing intensive help.
Got it. Prodromal is the lead up, acute is the severe part. Now, the guide calls this the schizophrenia spectrum. That implies it's not just one diagnosis.
Correct. The spectrum idea covers disorders that share features, mainly psychosis, but they differ in how long they last, how severe they are, the specific symptom mix.
So schizophrenia itself is the classic one.
Right. Chronic, often severe, typically starting late teens, early 20s.
And how does schizophreniform disorder fit in? Your guide mentions that one.
Duration is the key difference there, according to your source. Schizophreniform has the same kind of symptoms as schizophrenia,
Okay.
but they've been present for less than 6 months. And the guide also notes that the functional impairment might not be as severe as in full schizophrenia, at least when it's diagnosed.
So kind of like schizophrenia, but shorter duration. What about delusional disorder?
With delusional disorder, the main thing is having delusions for at least a month. But here's the key differentiator. Outside of the impact of that specific delusion, the person's overall functioning isn't usually markedly impaired.
Oh, okay.
And hallucinations, if they happen, aren't prominent and usually tie directly into the delusion. The false belief is really the central problem.
Got it. Focus on the belief. Brief psychotic disorder. Sounds self-explanatory.
Pretty much. It's a sudden onset and it's short. Psychotic symptoms pop up abruptly, last at least a day, but less than a full month. And importantly, your guide says there's a full return to their previous level of functioning afterwards.
Quick onset, quick resolution. And schizoaffective disorder. Sounds like a mix.
It is. It's a blend of schizophrenia symptoms plus a major mood episode. So major depression or mania or a mixed episode.
Okay.
What makes it different from, say, depression with psychotic features is that in schizoaffective disorder, the psychosis has to be present for at least 2 weeks, even when the mood episode isn't prominent.
Ah, so the psychosis lingers independently of the mood swings. That's a key distinction.
It is.
And one last one your guide highlights, which sounds crucial for assessment. Substance-induced psychotic disorder.
Oh, absolutely vital. Your source really stresses this. Psychotic symptoms, delusions, hallucinations can be directly triggered by substances.
Illicit drugs, alcohol.
Yep, or prescription meds, even toxins. As a nurse, sorting this out is a critical first step because the treatment isn't necessarily antipsychotics first. It's addressing the substance use. You have to rule this out.
That makes total sense. Huge implications for the care plan. Definitely need to be sharp on that for the exam. Okay, we've got the map of the spectrum. Now let's get into the symptoms, the core of your assessment. Your guide breaks them down. Positive, negative, cognitive, affective. Let's start with positive. These are things added, right? Things that shouldn't be there.
Exactly. Added experiences or behaviors. And the most well-known are probably hallucinations.
Which your source defines as sensory experiences without any actual external thing causing them. Seeing or hearing things that aren't there.
Correct. And auditory hearing voices is the most common type by far. But your guide mentions others too, like visual, tactile, feeling things, olfactory smelling, gustatory tasting.
And the guide points out one specific type of auditory hallucination that's a psychiatric emergency.
Yes, command hallucinations. This is critical. It's when the voices are telling the person to do something specific.
Oh, wow.
Your source highlights this because these commands can be incredibly dangerous commands to harm themselves or someone else. The example given is like, jump out the window.
Okay, so assessing for command hallucinations is a top safety priority.
Absolutely. You need to know the content of the hallucinations. Is it commanding? Is it threatening? That's basic safety assessment.
Makes complete sense. Safety first. Okay, beyond hallucinations, positive symptoms include delusions. False beliefs held strongly despite evidence, right? What example does your guide use?
The source gives the example of a persecutory delusion, believing coworkers are plotting against you to stop you getting a promotion, even with no proof.
Okay.
And the glossary adds related ideas like thought insertion, feeling like thoughts are being put into your head.
Wow.
And thought deletion, feeling like thoughts are being taken out. They all show distorted thinking about reality and external influence.
That sounds terrifying for the person experiencing it. All right, still on positive symptoms, your guide talks a lot about disorganized thinking and speech. Different patterns you might hear. Yeah.
Definitely. These show a breakdown in how thoughts are logically connected. Associative looseness, or looseness of association, is a big one.
Okay, what's that like?
The links between thoughts are just loose or illogical. Speech wanders, it doesn't quite track. One idea doesn't really follow the last one smoothly. It can become pretty incoherent.
So the ideas are sort of there, but jumbled or strangely connected. How's that different from clang association?
Clang association is all about sound, not meaning. The person chooses words based on how they rhyme or sound similar.
Ah, like rhyming for no reason.
Exactly. It creates this string of words that doesn't make logical sense. Sound takes over.
And word salad sounds messy.
It's the most extreme form. Just a completely jumbled mix of words and phrases, no logical connection, no sound connection, like tossing words in a blender, as your guide puts it.
Total communication breakdown. What about tangentiality?
That's when someone goes off on a tangent from the question or topic.
Okay.
And just never gets back to the original point. They wander off and stay off.
Takes a detour and doesn't return. And neologisms.
Made up words. They mean something to the person using them, but nobody else knows what they mean.
And symbolic speech.
Using words or phrases to represent something else, often an internal feeling, but not literally. The guide's example is, demons are sticking needles in me.
Meaning they feel pain.
Right, sharp pain. Symbolized by that phrase.
That's a whole range of ways thinking can get disrupted. Your guide also quickly mentions other positive signs. Motor agitation, paranoia, pressured speech.
Yeah, more observable things. Motor agitation is that restless, excessive movement like pacing, often driven by inner turmoil. Paranoia is that intense, irrational suspicion. And pressured speech is talking really fast, urgently, hard to interrupt. All signs of unusual internal states. Got
it. So those are the additions. Now let's flip to the subtractions, the negative symptoms. Your guide says these are often tougher to treat and really hit quality of life hard. Connects to that essay question, right?
That's a really key point, yes. Negative symptoms are the absence or loss of normal functions or feelings. They can be less dramatic than positive symptoms, but they're incredibly disabling.
Like anhedonia. What's that again?
Anhedonia is the reduced ability to feel pleasure from things you used to enjoy.
Okay. And avolition.
That's a lack of motivation or drive. Difficulty starting tasks, following through, big impact on daily life.
Alogia. Sounds like logic, but...
It means poverty of speech, basically. A reduction in how much someone talks. Replies might be really brief, they might seem reluctant to talk.
Affective blunting.
That's a reduction in emotional expression. Their face might look flat, their voice might not have much inflection, even if they're feeling emotions inside.
Okay. And apathy.
Similar to avolition, but more about a general lack of interest or concern about things.
And negativism.
That's resistance, either passively or actively resisting instructions or attempts to be moved or helped, like just opposition.
So negative symptoms really paint this picture of withdrawal, reduced drive, less emotional expression. You can see how that would affect functioning, even if the hallucinations are controlled.
Exactly. Positive symptoms might get you hospitalized, but negative symptoms often make it really hard to go back to work, keep up relationships, enjoy hobbies.
Right. Your guide also covers cognitive symptoms. How do these fit in?
Cognitive symptoms affect thinking processes, memory, attention, decision-making. Things like impaired memory, shortened attention span, poor judgment, trouble with impulse control, difficulty prioritizing tasks, problems with problem solving. They're not always obvious from the outside, but they hugely impact daily functioning.
And the glossary mentions concreteness and cognitive retardation here.
Yeah, concreteness is taking things very literally. Difficulty with abstract thought, like the example, pull yourself together. They might actually try to physically do that.
Yeah.
And cognitive retardation is just a general slowing down of thinking and responding.
And affective symptoms.
Yeah.
Affective blunting came up again, and the mood link to schizoaffective disorder.
Right. Affective symptoms are about mood and emotion. Blunting is common in schizophrenia, but those distinct mood episodes, depression, mania, are what define conditions like schizoaffective disorder.
Okay. Your glossary has a few more crucial assessment terms. Anosognosia. That sounds really important for nursing.
Oh, anosognosia is absolutely critical. It means lack of insight. The person doesn't recognize they have an illness or need treatment.
They don't believe they're sick.
Correct. And you can imagine that's a massive barrier to getting help, sticking with meds, engaging in therapy. Recognizing anosognosia totally changes how you, as a nurse, approach education and building trust.
Yeah, hard to educate someone about an illness they don't think they have. What about depersonalization and derealization?
Those are dissociative experiences. Depersonalization is feeling detached from yourself, like you're unreal or observing yourself from outside.
Right.
Derealization is feeling like the world around you is strange, different, or unreal. Both can happen alongside psychosis.
Psychopraxia.
That's mimicking someone else's movements involuntarily.
And illusions. How are they different from hallucinations again?
Important distinction. An illusion is a misinterpretation of a real stimulus. Something is there, but you perceive it wrongly. The guide's example. Seeing a coat on a rack in a dark room and thinking it's a person or a threat. There's a real coat, but your brain misinterprets it. Hallucinations have no external stimulus.
Got it. Illusion, misinterpreting something real. Hallucination, perceiving something not real. What about impaired impulse control?
Just what it sounds like. Difficulty resisting urges or impulses can lead to unpredictable or risky actions sometimes.
Magical thinking?
Believing your thoughts or actions can directly control external events in ways that defy logic or physics.
And motor retardation.
A visible slowing down of physical movement and activity.
Wow. Okay, that is a really thorough look at all the different symptoms and related things covered in your source.
Yeah.
Understanding this whole range seems absolutely foundational for assessment.
It really is. Being able to spot these symptoms, describe them accurately, ask the right questions, that's where everything starts. Patient safety, care planning, everything.
And often, that care plan involves medication. Antipsychotics are central, right? Especially for positive symptoms.
Yes, they're a cornerstone of treatment. Your guide mainly talks about two classes. First-generation antipsychotics, or FGAs, and second-generation antipsychotics, SGAs, sometimes called typical and atypical.
And the main difference in how they work, according to the guide.
FGAs primarily block dopamine receptors, specifically the D2 type. They're strong dopamine blockers.
Right.
SGAs are often described as having a broader action. They block dopamine D2 receptors too, but also serotonin receptors like 5-HT2A. This difference might account for why they sometimes have different side effect profiles or maybe work differently on certain symptoms.
And your source mentions LAIs, long-acting injectables.
Yes. Those are really important from a nursing standpoint, especially thinking about things like anosognosia or just difficulty remembering daily pills.
Right, for adherence.
Exactly. You get an injection every few weeks or even months instead of needing daily pills. It ensures consistency of treatment.
Makes sense. Now, side effects.
Yeah.
Huge focus in your guide, definitely key exam territory. Let's talk EPS, extrapyramidal symptoms.
Yes. EPS is an umbrella term for a group of motor side effects, especially common with the older FGAs because of that strong dopamine blockade.
What kind of things are we talking about? What examples does the guide list?
It lists akathisia, that intense inner restlessness, feeling like you have to keep moving, pacing, fidgeting,
Okay.
pseudo-Parkinsonism, which looks like Parkinson's disease, tremors, muscle stiffness, shuffling walk, maybe a mask-like face with little expression,
Right.
and dystonia, involuntary muscle spasms. Can be quite painful, cause weird postures, often affects the neck, eyes, or tongue first.
Okay, those sound significant. And your source seems to really zero in on tardive dyskinesia, or TD, within that EPS group.
It does, and rightly so. TD is a type of EPS that can become persistent, sometimes even permanent, even after stopping the medication. That's why it's such a concern.
And what does it look like?
It's characterized by involuntary rhythmic movements. Often starts in the face and mouth, lip smacking, tongue movements, grimacing, chewing motions. But it can also affect limbs or the whole body.
And the crucial tool for monitoring this that your guide mentions.
The AIMS tool, Abnormal Involuntary Movement Scale.
AIMS. Got it.
Yeah, it's a standardized rating scale nurses use to systematically check for and score these kinds of movements. Regular AIMS assessments are essential for early detection and tracking TD. You absolutely need to know the AIMS tool.
Definitely highlighting that one. Okay, what other side effects from antipsychotics, especially FGAs maybe, does your guide point out?
Metabolic syndrome is a big one. It's actually a risk with many SGAs too, but your source lists it here. It's that cluster of issues. Significant weight gain, messed up cholesterol and triglycerides.
Dyslipidemia?
Right, dyslipidemia and insulin resistance, which increases the risk for diabetes and heart disease. Also, neuroendocrine effects like hyperprolactinemia, too much prolactin, which can cause menstrual problems, sexual dysfunction, even lactation.
Wow, quite a range. And finally, some rare but really serious ones flagged in the guide.
Yes, less common, but you have to know them. Neuroleptic malignant syndrome, NMS. It's rare, but life-threatening.
What are the signs?
High fever, extreme muscle rigidity, confusion or altered mental status, and autonomic instability. Things like blood pressure and heart rate going haywire. It's a medical emergency.
Okay.
And severe neutropenia. That's a dangerously low count of neutrophils, a type of white blood cell. It's a specific risk with one SGA, clozapine.
Clozapine.
Yep. Makes patients highly vulnerable to serious infections. That's why anyone on clozapine needs regular blood monitoring, checking those white cell counts.
Okay, so a lot to monitor with these medications, bringing it all together then, understanding these symptoms, the different disorders, the meds, and their side effects. It all comes back to nursing care, assessment, and especially safety.
Right, absolutely. Everything we've discussed, recognizing that voice might be a command hallucination, understanding why someone holds a delusion so firmly, spotting akathisia or the early signs of TD, knowing about anosognosia, it all directly informs your assessment.
It tells you what the patient is experiencing and what the potential risks are.
Exactly. And while your guide might not give detailed care plans, knowing someone has impaired reality testing tells you communication needs to be clear, simple, concrete. You don't argue about the delusion, you focus on the feeling behind it, and always on safety.
Right, and recognizing something like command hallucinations, as you said, immediately flags a high safety risk.
Precisely. Your assessment skills, built on understanding these concepts from your guide, are your primary tools for keeping patients safe and figuring out the right interventions. Even knowing about anosognosia changes your whole approach to building rapport and talking about medication.
This has been a really packed deep dive into your study material. We hit the basics of psychosis, reality testing.
Differentiated the spectrum disorders, schizophrenia, schizophreniform, delusional, brief psychotic, schizoaffective, and that crucial substance-induced type.
We broke down all those symptoms, positive like hallucinations, especially command, and delusions, the disorganized thinking patterns.
Yep. And the negative ones like anhedonia, volition, plus cognitive and affective symptoms. And those key glossary terms like anosognosia, depersonalization, derealization, illusions versus hallucinations.
And crucially, the meds, FGAs, SGAs, the role of LAIs for adherence.
And those critical side effects, EPS, especially tardive dyskinesia and the AIMS tool, metabolic syndrome, and the serious ones like NMS and neutropenia with clozapine.
All pulled straight from your guide, forming that core knowledge you need for the mental health nursing exam. Mastering this is really key.
It really is. For the exam and for practice.
Definitely. So just to leave you with a thought as you keep studying, when you think about this huge range of symptoms, how profoundly they affect someone's reality and function, how does knowing the biological side, the neurotransmitters, how the meds work, their side effects, how does that shape the way we provide truly compassionate, person-centered care that aims for recovery? not just symptom control.
Yeah, connecting that biology to the lived experience, that's where deeper understanding and better nursing practice comes from.
Go crush that exam.